Assalamualaikum everyone. My name is Rida Shahab. I'm a third year medical student, and today I'll be covering the pharmacology crash course for the autonomic nervous system drugs. So let's get this started with. The slides are too many, I know. Your doctor changed this year, so I tried to be as inclusive of slides. I included all the drugs that were in your lecture. So please bear with me, inshallah, it's going to be a short crash course. All right, so these are going to be our table of contents for the day. First, we're going to cover what autonomic nervous system is really quick. Then we're going to talk about cholinergic agonists, cholinergic antagonists, and then we're going to jump into adrenergic agonists and then adrenergic antagonists. Okay, so starting off with what our autonomic nervous system is. So we have this nervous system, which is divided into the central nervous system and the peripheral nervous system. Now, the peripheral nervous system is further divided into afferent and efferent. Now, peripheral nervous system is our star for the day. This is going to be our main focus, okay? Now, afferent division is where all the signals arrive. So if anything's arriving, that means it's sensory, okay? So AA. Afferent arrives, so it's sensory, okay? So we're going to completely forget about afferent division right now because it's related to senses. Probably going to take it in the neuro block. We're going to focus on the efferent division. Now, the efferent division is from E, it's exiting, and what exits? Your reflexes exit, your motor nerves exit to bring your reflexes to your muscles so you can act, right? So efferent division is the motor division. Now, efferent division is further divided into somatic and autonomic nervous system, right here, as you can see. So you have the peripheral nervous system, and then your efferent, which is your muscle, or so your motor system, is further divided into somatic nervous system and autonomic nervous system. Now we're going to cover somatic nervous system and then autonomic nervous system. Now, what is the autonomic nervous system in general? It's just the division of your peripheral nervous system, right, that controls involuntary functions of your body. That's going to include your heart rate, your respiratory rate, your digestion, your gland secretion. Everything that's involuntary is controlled by your autonomic nervous system. Okay, now the brain, specifically the hypothalamus, it just integrates all the signals for both neural and endocrine responses. Okay, now autonomic nervous system, how does it communicate? There are neurotransmitters that coordinates this action between your central nervous system and your peripheral nervous system. Okay. Now coming to the autonomic nervous system divisions. So you have the autonomic nervous system, which comes under peripheral nervous system, which comes under the nervous system. I hope you understand that. Now, autonomic nervous system in itself is further divided. So you have sympathetic nervous system, parasympathetic nervous system, and enteric nervous system. So sympathetic, parasympathetic, and enteric. Now, from their names, very easy to remember, or an easy way to remember this is that sympathetic nervous system is going to prepare your body for fight or flight. So if you're in a dangerous position, your sympathetic nervous system gets activated, okay? So you're going to have high heart rate, you're going to have dilation of your pupils, the bronchioles are going to dilate so to get more oxygen because you're in a stressful condition. So anytime you're in a dangerous situation, your sympathetic nervous system gets activated. Parasympathetic, however, is quite the opposite. Parasympathetic is rest and digest, which is when you're relaxing, your parasympathetic nervous system is working. Enteric or enteric nervous system is the nervous system that regulates the GI. So GI motility, GI secretions, everything GI related is under enteric nervous system. And very interestingly, actually, it can also function independently. It doesn't need input from the sympathetic or the parasympathetic nervous system. Now, coming on to somatic nervous system. Somatic in itself is just from the name soma, so muscles. So it's going to handle all the reflex arcs, everything like that. Autonomic nervous system is going to do more of, like the involuntary body functions. That's what it do. Okay. Now, for the somatic nervous system and the autonomic, the main difference between these two is how the signals are relayed on. Okay. So somatic nervous system has one neuron only that goes from the central nervous system to the skeletal muscle. There's no ganglia in the middle, okay? So it just goes from the central nervous system to the skeletal muscle, and there's like a reflex, okay? Autonomic, on the other hand, there's two neurons that are working. So there's going to be preganglion and postganglion. So This is somatic nervous system, for example. Somatic nervous system is just going to have one neuron that goes from the central nervous system to the muscle, okay? And it's going to act, there's going to be a reflex. But autonomic nervous system is different because autonomic nervous system has two ganglions. So there's going to be a preganglion, so there's going to be the pre, then there's going to be the ganglion that synapses at, and then the postganglion is going to come out from here, and then it's going to go to the respective muscle, gland, whatever it is, okay? So that's how preganglion and postganglionic under autonomic nervous system work. Okay, so now coming on to the division of somatic nervous system in general. Somatic nervous system, as we said, has a single neuron that goes from the central nervous system to the muscle. Now, what about the neurotransmitter? What neurotransmitters are used? Now, in somatic nervous system, the main neurotransmitter that's used here is your acetylcholine, which is really important to remember. Okay, acetylcholine is mostly used everywhere. You're going to see exceptions in the cases later on, but in somatic nervous system, remember that the neurotransmitter that's used is acetylcholine. You can see it in the picture here. You can also see that the neuron is just one single neuron that's going from the central nervous system to your muscle. So this is your muscle, okay? I don't know why I'm using the thing when I should be using the laser. Anyways, so the effectors are going to be your skeletal muscle. Action is voluntary, okay? The reflex, voluntary actions, all of this somatic nervous system. This is just another picture that compares it. So central nervous system is just going to be the motor neuron that goes to the skeletal muscle. There's going to be no ganglia in the middle. So neuron to the muscle. Okay, so again, as we said, this is just a brief overview of the somatic nervous system. It's just gonna, be responsible for voluntary movements. We discussed the pathway. The neurotransmitter is gonna be acetylcholine, and it acts at the nicotinic receptors, which we're gonna get into. For now, just know it acts on the nicotinic receptors. Okay, at the neuromuscular junction, which is gonna cause the muscle contraction in order for you to do these voluntary movements. So it's gonna control like all of your voluntary muscle activities. It also carries sensory information, and it's also responsible for the reflex arcs. Now, coming on to the reflex arc, it's really easy and it's really important to understand as well as it was in your slide. So let's say, for example, how does the reflex arc happen? So there's five main parts. There's the receptor that detects the stimulus, and then there's the sensory neuron. Now, the sensory neuron is the neuron that's going to carry the signals. So it's going to take these signals to the central nervous system. Then it's going to get integrated, or it's going to get, read in your brain that there is something happening. And then there's a motor or an efferent neuron that exits the central nervous system to go act on the muscle. So that's how it usually is. Okay, so you have, where's my point two? Okay, so you have your receptor, right? You have your receptor, then your receptor goes and detects the stimulus. My bad, it detects the stimulus right here. The sensory neuron is gonna carry this input to the central nervous system. So from the central nervous system, it's gonna get integrated, and then from your central nervous system, there's gonna be your efferent neuron that comes out, and then there's gonna be your effector organ that is gonna, do the movement. For example, if you touch something hot, right, the receptor is going to detect that this is hot. It's going to take the sensory neurons to your central nervous system, tell it it's hot. Then the central nervous system is going to get the efferent neurons to go to your hand and push it back voluntarily. So you don't, as a reflex, you don't want to touch it again. Okay, now coming on to the autonomic nervous system, we have covered the somatic nervous system. Now, autonomic nervous system has its own parts, right? We said sympathetic, parasympathetic, enteric. Now, getting to sympathetic first. Now, sympathetic pathway, we talked about how the neurons are not one single neuron. There's going to be preganglionic and postganglionic. Now, in sympathetic, they're going to be called preganglionic sympathetic, postganglionic sympathetic. In parasympathetic, it's going to be preganglionic parasympathetic, postganglionic parasympathetic. That's how it works. For for sympathetic pathway in general, the preganglionic neuron is shorter. The axon for the preganglionic is shorter. Okay, so sympathetic, we're gonna have two neurons. The first neuron, right, is gonna be short. Then there's gonna be the ganglion, and then the other neuron is gonna be longer. So this postganglionic is gonna be longer. Preganglionic is gonna be shorter. Okay, but it's quite the opposite in parasympathetic. Pre is longer and post is shorter. Okay, so now, okay, we know that there's preganglionic and postganglionic, but what's the purpose of this? What does it do? Now, Preganglionic in itself, it starts in the spinal cord. Now, both sympathetic and parasympathetic, they have different origin of sites, okay? So, for example, preganglionic sympathetic is going to start from thoracolumbar. So, the origin is going to be thoracolumbar, okay? That's where the signals arise from, okay? And it's going to be different for parasympathetic. So, preganglionic signals arrive from the thoracolumbar, okay? It's going to be a short axon, and then it's going to come at the ganglion, okay? And then at the ganglion, it uses acetylcholine. Now, acetylcholine is here at the ganglion. This postganglionic is then going to read, oh, okay, the preganglionic is trying to send me a signal. The postganglionic, with the help of acetylcholine, is going to read this, and the long axon is then going to go towards the organ. And then at the organ, it's going to use norepinephrine to, do its function, such as increasing heart rate, etc. Okay? But the only exception here is sweat glands. Now, what do you mean the only exception is sweat glands, Rida? Preganglionic, we said it uses acetylcholine at the ganglion. And then when the postganglionic is taking the signal out, it uses norepinephrine at the organs. Sweat glands don't use norepinephrine at the organs. Instead, they use acetylcholine. So it's going to be acetylcholine in the ganglion, and it's going to be acetylcholine at the sweat gland organ, okay? So, for example, let's focus on this diagram right here. You see that there's the preganglionic axon, right? I'm sorry, my throat is a bit it's a bit dry, so that is why my voice is not, the way it is. I'm sorry, I hope that doesn't bother you guys. Anyways, so we're starting with the preganglion, right? The preganglion is shorter. It's arising from the thoracolumbar region, okay? The signals come from there. Now it's gonna synapse at the ganglion, it's gonna release acetylcholine. Acetylcholine gets released, the postganglionic reads it. Postganglionic is a longer axon, it's gonna go to the organ, and it's gonna release norepinephrine, which is gonna, make the organ active, it's gonna activate it, there's gonna be increased heart rate, there's gonna be dilation of the, ciliary muscles. And etc. Yeah. Okay. So that's how that works. Because if it's a sweat gland, what's going to happen is this is the short axon, which is a preganglionic. The postganglionic, there's going to be acetylcholine in the ganglion, right? The postganglionic, when it reads and it's going to the organ, instead of norepinephrine here, it's also going to secrete acetylcholine. So it's going to be acetylcholine here and it's going to be acetylcholine there. So that's sweat glands. That's the only difference. Okay, that's the only exception in sympathetic. So postganglionic sympathetic for sweat glands is going to be acetylcholine. But postganglionic sympathetic for every other organ is going to be norepinephrine. So I hope that makes sense. Now, neurotransmitter for most of the postganglionic sympathetic nerves is going to be norepinephrine, as we discussed, but sweat glands in themselves are going to use acetylcholine. Now, what are the receptors for sympathetic? Now, sympathetic nervous system and your autonomic nervous system acts on two receptors, so alpha and beta. Now, these are really important to remember. Now, alpha is divided into two, which is alpha 1 and alpha 2. Beta is divided into beta 1, beta 2, beta 3. Now, we're going to get into what each of these do in more details as we're covering the adrenergic part. But just remember that sympathetic nervous system in general is controlled by your receptors, which are your alpha and beta. And if you want to have drugs that are acting on alpha and beta, you're directly inhibiting or activating sympathetic nervous system. And so this class of drug that acts on alpha or beta receptors are called adrenergic receptor drugs, okay, or adrenergic drugs. And they could be adrenergic agonists or they could be adrenergic antagonists, depending on their action, okay? So that's how, okay, adrenergic, we're talking about sympathetic nervous system. They're affecting the sympathetic. If you're talking about cholinergic, then it's affecting the parasympathetic nervous system. Okay, very, very important to differentiate between these two. So, as we said, alpha 1, alpha 2, usually they cause vasoconstriction in the blood vessels, right? For beta 1, beta 2, beta 3, the easiest way to remember them, for me, it was beta 1 acts on the heart, right? So it's going to increase the heart rate because beta 1 is just one. But beta 2 is going to act on the lungs and it's going to cause like bronchoconstriction. Now, beta 2, because it's two, there's two lungs. That's how I remember it. Okay. And there's also muscle relaxants and vasodilation. So that's alpha and beta for adrenergic receptors, or basically they're called adrenergic receptors, which are for sympathetic nervous system. So this is just an image from your slide. It shows the different actions of sympathetic nervous system. What exactly does the sympathetic nervous system do? So we know it's going to dilate your pupils. There's going to be CNS alertness. Remember, sympathetic gets activated when you're in a dangerous situation. So heart rate is going to increase, the force is going to increase. There's going to be lipolysis, and the bladder, the sphincter tone is going to increase, but the detrusor muscle is going to decrease. So you're basically going to, not have the urge to urinate because you're in a stressful situation. Then you have the liver. For the GI, the peristalsis and everything is going to decrease. Sphincter tone is going to decrease because you're in a stressful situation. And also for the secretions, they're going to be little secretions, okay? Saliva is going to be little, for example. So that's how sympathetic nervous system works. And this is just a diagram also from your slides that talks about the preganglionic and postganglionic sympathetic fibers. So preganglionic is always shorter and postganglionic is always longer. Now, in usually all blood vessels, organs, etc., it's going to be acetylcholine and then norepinephrine, right? But in your sweat glands, which is the only exception, it's going to be acetylcholine and then acetylcholine again. Okay, and then adrenal medulla in itself is a sympathetic, it's known to be a sympathetic ganglion. Okay, so in itself is a ganglion. So this is where the signals are relayed out of. So it has acetylcholine that goes there, and then adrenal medulla is going to further go activate the other organ. So in itself, it's a sympathetic ganglion. Okay. Now, coming on to the parasympathetic nervous system. Parasympathetic nervous system, the preganglion is going to be shorter. No, sorry, the preganglion is going to be longer as compared to the sympathetic one, and the postganglionic here is going to be the shorter one. Now, interestingly, parasympathetic is really easy because on both sides you're going to have acetylcholine. Okay, so at the ganglion you're going to have acetylcholine, and at the effector organ or wherever it's going, it's going to be acetylcholine as well. Okay, but the only difference is the preganglionic is going to be longer and the postganglionic is going to be shorter. Now, as we discussed, the origin is also going to be different. The origin for parasympathetic is going to be craniosacral. For sympathetic is with thoracolumbar, and for parasympathetic it's craniosacral. Very important to remember, this could be a direct question in your exams where they ask you, okay, where do the parasympathetic preganglionic nerve fibers arise from? It's going to be craniosacral. Where do the sympathetic preganglionic nerve fibers arise from? It's going to be thoracolumbar. Okay, so really important to remember that. Now, we discussed this as well. For neurotransmitters in general and parasympathetic, preganglionic, postganglionic both have acetylcholine, as we discussed. But sympathetic is going to be different because it's going to have norepinephrine, except, of course, your sweat glands. Now, the receptors in parasympathetic are also going to be different. For sympathetic, we said it's going to be the alpha and the beta receptors, which are called adrenergic altogether. Now, receptors under parasympathetic, they're altogether called cholinergic, but cholinergic receptors are divided too. Now, the receptors are going to be nicotinic and muscarinic. Now, nicotinic in themselves, they're just going to be, for the neuromuscular junctions, etc. But muscarinic are the ones that are going to go and act on the organs. So your lungs, your heart, your stomach, all of that, that's going to be your muscarinic receptors, okay? Nicotinic is just the ganglion as well as the neuromuscular junction receptors. So nicotinic, muscarinic are under parasympathetic, and the class that they fall under is cholinergic, okay? So when we're talking about cholinergic drugs, we're referring to drugs that are working on the parasympathetic nervous system under the autonomic nervous system, okay? I hope that's clear. When we're talking about adrenergic class of drugs, we're talking about we're talking about drugs that act on the sympathetic nervous system under the autonomic nervous system. So that's that. This is again just from your slides. It shows what the functions of parasympathetic nervous system are. We said that because it's the nervous system of relaxing. When you relax, this nervous system gets activated. So there's going to be, mydriasis of your eyes. So your eye ciliary muscles are going to constrict, okay? And then your bronchoconstrict, there's going to be bronchoconstriction, secretion, because there's going to be bronchodilation where in the sympathetic nervous system, okay? The heart rate and everything is also going to decrease. The GI secretion is going to increase, but peristalsis is also going to increase. Sphincter tone is going to decrease. The bladder tone is going to the sphincter tone is going to decrease, but the detrusor tone is going to increase, which means that, you're going to have the urge to urinate and stuff. So yes, so this is a parasympathetic nervous system neuron. So as you can see, there's a preganglionic, which is longer. And then there's the postganglionic, which is going to be shorter. In the picture, you can't really tell, but the postganglionic has to be shorter, and the preganglionic has to be longer. In this picture, you can clearly see preganglionic is longer and postganglionic is shorter. Okay, so don't get confused by this picture. Now, both are going to use acetylcholine, and then it's going to go to the effector organs and do its act. This is just an overview. So we discussed the somatic nervous system. Somatic nervous system is just going to have that one neuron that is going to go and act on the muscle. There's going to be no ganglion. Sympathetic nervous system in itself has a ganglion. There's going to be preganglionic, postganglionic. Preganglionic is shorter, postganglionic is longer. And then your ganglions are always going to have acetylcholine. Remember that. But if it's sympathetic nervous system, and it's like normal organs, then the postganglionic sympathetic nerve fiber is gonna go and release norepinephrine. But if it's sweat glands, it's gonna be acetylcholine. Okay, and for parasympathetic, it's gonna be acetylcholine in the effector organs. This is also from your slide. It just shows that in the fight or flight situation, your sympathetic gets activated, and in the rest and digest, your parasympathetic is activated. Okay? And then if you notice the axons, in parasympathetic, it's both acetylcholine, both preganglionic and postganglionic. But in sympathetic, preganglionic is acetylcholine, but postganglionic is norepinephrine, unless it's a sweat gland. This picture just summarizes everything. Now, the main focus of this picture is to see that your sympathetic is arising from thoracolumbar and your parasympathetic is arising from craniosacral. So this is craniosacral, right? And everything that's arising from like right here, like from here, is gonna be all parasympathetic. Thoracolumbar, which is gonna be all of this, is gonna be sympathetic. Okay, because thoracolumbar is sympathetic. That's where the preganglionic nerve fibers arise from. Now, coming on to the enteric nervous system. Now, what's the enteric nervous system? This is just the third division of autonomic nervous system, and it controls the GI tract. Now, there's two key plexus that you need to know. There's Mesenter's plexus and there's Orbic's plexus. Okay, now Mesenter's is just going to control the GI secretions, and Orbic is the one that controls the GI movements. So GI secretions is going to be Mesenter's. Orbic is going to be the GI muscle movements. Okay, so remember that. It's just it's just the brain of the gut. There's going to be plexus in the gut. The gut doesn't need signals. It has to do its own involuntary action, and that's why there's an enteric nervous system there. This is just a table of summary. You guys can go over this as to just revise the above lecture that we just mentioned. For the neurotransmitters, we said that, okay, we discussed norepinephrine, acetylcholine, okay? Now these neurotransmitters are basically chemicals that are going to transmit the signals, right? That's what they do. Now, there's going to be different types. So there's acetylcholine, which is the main transmitter. And then there's going to be monoamines. Now, under monoamines, you have catecholamines. Catecholamines is going to be norepinephrine, which is, again, mainly sympathetic because everything, as you saw, was by norepinephrine except sweat glands. There's also epinephrine, which is going to be from the adrenal medulla, and then dopamine. And then there's going to be indolamines, which is going to be serotonin, and there's also going to be others. The amino acids are going to be your glutamate, GABA, glycine, all of that. You're going to have your peptides. What's important to know here is that acetylcholine and that there's monoamines under which there's catecholamines, under which there's norepinephrine and epinephrine. Now there's more neurotransmitters, there's hormone mediators, such as morphine-like substances. Endorphins, enkephalins, they're gonna block the pain receptors, right? You don't want to feel pain, so that's what they do. There's also other peptides like insulin, which are gonna regulate your glucose, prolactin, which is gonna, produce milk, and there's also vasopressin, which is gonna control your BP, blood pressure. Now, for the signal transduction, this is just how these neurotransmitters actually act in your neuromuscular junction. So again, our major types are acetylcholine, right, and our norepinephrine or epinephrine. Okay, now norepinephrine, epinephrine are going to be adrenergic, whereas acetylcholine is going to be called cholinergic. That's the term for them. Okay, now there's going to be different receptor types. We discussed this. We said if it's muscarinic and nicotinic, it's going to be falling under cholinergic, right? So this cholinergic, muscarinic, and nicotinic is going to be for the parasympathetic. For alpha and beta, it's going to be sympathetic, okay? Just to link stuff. Now, one second. Now, signal transduction. That's what it is. How does this happen? So there's going to be the precursor neurotransmitter that's going to be synthesized. Now, this gets synthesized. It's going to be synthesized. It's going to go into the vesicle and then it gets released. Now, sometimes there's a few neurotransmitters that you're going to take in the future, but I don't know if you're going to cover it in this block, that needs to be broken down for it to be activated. So they're going to be broken down in the cleft. Sometimes they just don't need to be broken down. And what they do is they just attach to the receptor, go in, and then they're going to, do the mechanism of action that they're responsible for. Okay. And sometimes also what happens is there's a lot of neurotransmitters in the cleft. Now these neurotransmitters, they're going to get recycled back up. Okay. So they can get recycled back up, they can be broken down, or they can be taken into the receptors for their mechanism of action. Now, for the breaking down of the neurotransmitters, there's very important enzymes that you need to know. Acetylcholine is broken down by acetylcholine esterase, okay? So acetylcholine is going to be broken down by the acetylcholine esterase in the cleft, okay? And norepinephrine, epinephrine is broken down by monoamine oxidase as well as catecholomethyltransferase. So monoamine oxidase and catecholomethyltransferase is what's going to break down your norepinephrine and epinephrine. This is just how, the receptors are divided for sympathetic and parasympathetic. So this is just for your own knowledge. And it's really important to know this. Just know that beta 1, as we discussed, it's going to be for the heart and the sympathetic. And the vessels are going to be alpha 1. Lungs is going to be beta 2. GI is going to be alpha and beta both. They're both going to work on it. Relaxation is going to be alpha 1 as well as beta 2, yes. And then I is also going to be alpha 1, okay? For parasympathetic, we said that muscarinic receptors are the one that goes to the lungs. That goes to the organs, effector organs. So there's 5 different types, M1 to M5. Now, M1 to M3 are our most important ones because M4 to M5 are for central nervous system, okay? Now, for M1, it's gonna be the central nervous system as well as the GI, right? M2 is gonna be the heart, and M3 is gonna be your like glands, lungs, everything else, okay? All the other organs. So if you're talking about heart, it's gonna be M2, okay? If you're talking about a dilatation of the vessels or anything else, any organ in general, it's gonna be M3. Even lungs, it's gonna be M3, okay? Glands in itself is gonna be also M3. GI in itself is going to be M1. Remember that, okay? So bladder, eye, everything is going to be M3. Okay, so this is just from your lecture again. It just shows you that all of these receptors, they have their preganglionic and their postganglionic, right? Now, the preganglionic in the sympathetic one, right here, there's acetylcholine. This is going to be the short axon. This is going to be the long axon, by the way. And it's going to be norepinephrine that goes to the different effector organs. It acts on the nicotinic receptor. Okay, these are all nicotinic receptors. Nicotinic receptors are receptors for the acetylcholine, and nicotinic receptors in themselves are further divided. They're divided into NN and NM. So NN is neuronal, okay? So it's going to be like found in ganglions, etc., whatever, right? And then NM is going to be your wait, hold on, my bad. NM is going to be for the muscles. So these acetylcholine receptors are going to be found on the muscles. So that is what this picture is showing here. You remember the somatic nervous system? We said everything goes to the muscles for the reflex arch. There's no ganglion. So there's going to be no NN receptor here. Instead, there's going to be an M receptor because it's directly going and acting on the muscle. So there's an M receptor right here, okay? An N receptor is going to be in the ganglions. And everything goes from the ganglions to the effector organs, right? So acetylcholine is going to go to the ganglion and then it's going to go to the effector organ and then act. So all of these receptors are going to be NN. Okay, I hope that's clear. Now, just for the drugs in general, we discussed this very briefly, but we're just going to go over it again. Now, autonomic nervous system drugs, their primary target is either going to be sympathetic or parasympathetic, right? And if they're doing parasympathetic, then they're going to be called cholinergic agonists or antagonists, depending on the mechanism of action. For sympathetic, they're going to be called adrenergic agonists or antagonists. Now, sympathetic is going to have alpha and beta. Parasympathetic is cholinergic, basically, is going to have your muscarinic and your nicotinic. That's what we discussed here. We said, my bad. Okay, we said adrenergic, right, is going to use norepinephrine and epinephrine. Very important to remember. Adrenergic, which is sympathetic, is going to use norepinephrine and epinephrine. Remember, preganglionic, postganglionic, there is norepinephrine at the end, so it's going to use norepinephrine. And it could either be stimulated by your agonists, which are adrenergic agonists, or adrenergic antagonists that could inhibit the function. Okay, now cholinergic are parasympathetic, so muscarinic and nicotinic under them. They all use acetylcholine. Everything in cholinergic uses acetylcholine. There's no norepinephrine, and it's for the rest and digest. And they could be either activated by agonists or, not activated by antagonists or blocked by antagonists. Okay. Now, this is just muscarinic versus nicotinic. So you know there's cholinergic. Cholinergic has a further division, which is muscarinic versus nicotinic. So why do we have this division? Well, it's divided because muscarinic in themselves are going to act on the organs. They're going to act on the smooth muscle and the gland functions. Whereas nicotinic, sorry, not nicotine, nicotinic receptors, they're going to act on the ganglion as well as the neuromuscular junction. Okay, so I hope that's clear. So this is a simple location. So muscarinic is going to be the organs, nicotinic is going to be the nerve junctions and ganglion and, all the other neuromuscular junctions. That's for our first lecture. And that brings us to our first question. So, what is the sympathetic postsynaptic neurotransmitter for sweat glands? So I'm going to give you guys 5 seconds. Okay. So the answer here is acetylcholine. I hope you guys answered that right. So usually in sympathetic, it's always norepinephrine, right? Except sweat glands where there's acetylcholine. It's norepinephrine. I don't know why I wrote an R. Okay. Now, from which spinal segments do parasympathetic preganglionic neuronal cell bodies arise? It's parasympathetic, okay? Not sympathetic. Okay, so the answer here is C, sacral and cranial, because parasympathetic preganglionic nerve fibers, they're gonna they're gonna arise from the craniosacral, okay? But if they're talking about sympathetic, then it's gonna be thoracolumbar. Okay, now which one of the following is gonna degrade epinephrine? You remember the signal transduction process? So which one's gonna degrade epinephrine? Okay, so the answer here is A, which is monoamine oxidase. Remember, monoamine oxidase as well as catecholomethyl transferase are both going to break down epinephrine. Acetylcholine esterase is going to be for acetylcholine. It's going to break down acetylcholine. Okay, so that's our first lecture done. And now we're going to jump on to cholinergic agonists, okay? So, cholinergic agonists, we're just going to overview everything. Now, cholinergic in itself, as we said, is going to be working on the parasympathetic nervous system. Now, parasympathetic nervous system under cholinergic is going to have 2 receptors, muscarinic and nicotinic. Muscarinic is going to act on your organs, effector organs. There's 5 types. We're going to discuss this. And then there's nicotinic receptors that are further divided into NN and NM. NM is going to go act on the muscles. NN is neuronal, so it's going to go act on the neuromuscular junctions as well as the ganglia. Adrenergic receptors, not relevant here for now because we're going to discuss them afterwards, but they are for the sympathetic system, okay? We discussed all of this. We said sympathetic has norepinephrine and parasympathetic has acetylcholine. Now, this too is a very important table. It's just a comparison of sympathetic and parasympathetic nervous system in general. Okay, so you're comparing, okay, sympathetic nervous system, for example, it's going to increase the heart rate. Parasympathetic is going to decrease the heart rate. So they're gonna balance everything out. It's like they're maintaining homeostasis. That's what they're doing. Okay, so for adrenergic, for example, remember we are in a stressful situation. We need more oxygen, so it's going to bronchodilate. But cholinergic, on the other hand, or parasympathetic, is going to bronchoconstrict. Okay, and for pupils, it might get confusing, but just just remember, for when you're nervous, you don't want to focus on anything, right? So your pupils are going to dilate. You don't want to focus. So that's called mydriasis. But if you're parasympathetic, you're relaxing, you want to focus on what you're doing, right? So you're going to just constrict your ciliary muscles, and it's going to cause constriction of the pupils, which is meiosis. Okay, so that's how I remembered it. And then for GI, of course, when you're in a like in a dangerous situation, you don't want motility and secretions in your GI. So it's going to decrease that. The lacrimation is going to decrease. The urination is going to decrease. You don't want urgency to urinate when you're in a dangerous position. So all of this just makes sense. Just remember, flight or flight, rest and digest. So just like go hand in hand, okay? Now, what is the neurotransmitter of parasympathetic nervous system? Most important is acetylcholine. Everything is acetylcholine in parasympathetic. Preganglionic, postganglionic, wherever you go, it's acetylcholine. Ganglion, acetylcholine. Organ, acetylcholine. Remember? So that's really important. For parasympathetic, quick pop quiz. Is the preganglionic parasympathetic fiber long or short axon? It's long axon, okay? Okay. I don't know why I did that, but just to test your knowledge. I hope you all said long, because short is for sympathetic. Okay. Now, we discussed acetylcholine as a key neurotransmitter. It's released from the preganglionic as well as the postganglionic neurons, and it's also in the sympathetic postganglionic neurons, except your sweat glands. Oh no, actually two sweat glands, because it's acetylcholine. So sympathetic postganglionic neurons, two sweat glands. Okay. Now, you have your cholinergic receptors. Your cholinergic receptors are muscarinic and nicotinic. Muscarinic is further divided into M1, M2, M3, M4, M5. M4, M5 is going to be central nervous system. M1 is going to be neural, but there's also going to be like gland secretions in M1, right? In M2, it's going to be cardiac. In M3, it's going to be smooth muscles as well as GI. So it's a bit confusing, right, on what specific muscarinic receptor acts where, but just remember the heart is an M2, and M4, M5 is central nervous system. M1 in itself is just neural, and M3 is going to be like the glands and the smooth muscle, okay? And then further on, when we're doing our drugs, we're gonna figure out, oh, this is M1 because it's working here, because it's M2 because it's working on the heart, etc. Now, nicotinic is NN and NM. So NM is for the muscles, right? And NN is for the neurons or neural. Okay, now for the sites of cholinergic drug action, now this was in your slide, it's really important to remember. Now there's precursor transport blockade. Now if you want to block the precursor transport, it's going to be hemicolinium. Okay, that's going to block this. For if you're going to promote your transmitter release, we already discussed how signal transduction happens, right? So if you want to like promote your transmitter to release from the thing to the synaptic cleft, then you're going to use choline to promote it. But if you want to prevent it, you're going to use botulinum. So these two are opposite to each other. If you want to promote it, it's going to be choline. If you want to prevent it, it's going to be botulinum. Now, if you want to prevent the acetylcholine storage, because acetylcholine gets stored in the vesicle, if you want to prevent it, you're going to use a vesamicol, right? So vesicle vesamicol makes sense, because if you don't want to store acetylcholine anymore, you're not gonna want to store it in vesicles, so vesamicol. Then you have choline esterase inhibition, right, which is your choline esterase, which breaks down acetylcholine, is going to get inhibited. And if you're inhibiting the inhibitor, you're basically increasing acetylcholine, right? It's not going to get broken down in the synaptic cleft anymore. So the drugs are going to be pisostigyme and neostigyme, okay? And there's going to be agonist or antagonist, as we discussed. Also, I just wanted to add that NM is a neuromuscular junction. I think I said that neuromuscular junction is NN in the previous slide. It's not. NN is autonomic ganglion and central nervous system. Neuromuscular junction falls under NM. Okay. Okay, so for the nicotinic receptors and muscarinic receptors, now how do they work? Nicotinic receptors are ion channel ligated. So there's going to be a sodium influx, depolarization, and excitation. It's going to work, okay? Now, nicotinic are very easy. They're going to, just do the entire thing in a very short process. And muscarinic, on the other hand, they're going to use the G protein coupled receptors. If you remember G protein coupled receptors. Now, we said there's five muscarinic classes, right? M1 and M3. So M1 was neural, and M3 was the smooth muscles and the glands and everything, right? These are going to work through GQ. So they're basically going to activate phospholipase C, which is going to increase your IP3, and it's going to basically increase your calcium, and there's going to be contraction that happens. So that's M1 and M3. For M2, which was the heart, it uses GI, so inhibitory. So it's going to inhibit the adenylate cyclase. It's going to decrease cyclic AMP, and it's going to open potassium channels, right? So these are found in heart, smooth muscle glands, and central nervous system. These are just the sites. So we said that M1 and M3 are going to use GQ, whereas M2 is going to use GI. So M2 is going to be for the heart, okay? And then M1 is going to be neural, and then M3 is also going to be not neural, but it's going to be for glands. Okay, now coming on to the drugs, right? So now drugs can affect the cholinergic neurotransmission. Now there's going to be muscarinic receptor drugs. So there's going to be muscarinic either agonist or antagonist. Now there's also enzyme inhibitors. For enzyme inhibitors, what we mean is we want to inhibit the acetylcholine esterase enzyme. We don't want it to act because we want more acetylcholine in our synaptic cleft due to maybe several different diseases. So acetylcholine esterase inhibitors. Acetylcholine esterase reactivators is when your acetylcholine esterase is not working. So you have a lot of acetylcholine. Now, too much of something is also bad, right? So having too much of acetylcholine can also give you certain diseases, and that is why you wanna reactivate your acetylcholine esterase, which is the inhibitor, to break it down. And then you have your nicotinic receptor, which is gonna be basically they're gonna act on your ganglion and your neuromuscular junction. They are also gonna be agonists or antagonists. Okay, now coming on muscarinic agonists. Now, muscarinic agonists in themselves are also called parasympathomimetic drugs or agents. Now, what does this mean? This basically means that muscarinic agonists in themselves are just prolonging the activity of parasympathetic drugs, okay, or parasympathetic functions in general. Because it's agonists, it's just activating the parasympathetic nervous system even more, right? So it's going to mimic the acetylcholine. It's going to mimic the acetylcholine at the muscarinic receptor, and it also has a longer duration than acetylcholine. So these drugs that we're going to talk about, for example, butanol, pilocarpine, and Civimeline. This is how I say it. I hope it's right. But these three drugs, they have a longer action or duration of action than acetylcholine. So their parasympathetic functions are going to be longer. Okay. Now, acetylcholine, you cannot give it in itself as a parasympathetic or as a mediator. Why? Because it's going to act on both receptors first off, because you remember it's also in the sympathetic preganglion. So it's going to act on both receptors, and it also gets degraded first. So it doesn't have like a good half-life. Okay, the function of acetylcholine, because we said that these agonists they're mimicking acetylcholine. So wherever you give these drugs, they're gonna do all of these functions. Now, remember, we're talking about parasympathetic. And if you're saying that, okay, we're doing muscarinic agonists, that means you're just activating the parasympathetic even more. So your parasympathetic was rest and digest, so now you're just resting even more. So if you're talking about cardiovascular, it's there was already decreased heart rate, right? But it's going to decrease it more. So now these drugs, the purpose of these drugs is that, for example, a patient presents with a high heart rate, you're going to give this drug which is going to bring the heart rate down. Okay, so that's what these drugs do. So in the cardiovascular system, it's going to decrease heart rate and it's going to decrease cardiac output. It's going to decrease blood pressure, okay, because it's going to vasodilate your blood vessels. How does it vasodilate? Through nitric oxide. That's all you need to know. It's going to vasodilate through nitric oxide. So it's going to decrease the blood pressure. It's going to decrease the heart rate. Okay, remember GI, we said it's going to increase the salivary secretion as well as intestine motility because you're relaxing. You're not in a rush anymore. The genitourinary tract, it's going to promote urination. Again, because you're in a relaxing mode, So even if you get the urgency to pee, you can go do it, right? So you're not in a fight or flight mode. Then for the eye, as we discussed, it's gonna cause pupil constriction because we said you want to concentrate on what you're doing and you're relaxing, right? So it's going to cause meiosis, which is going to be pupillary constriction. So it's going to constrict or contract the ciliary muscle, which is going to increase aqueous humor drainage. This is really important in glaucoma. Okay. Now, the adverse effects of muscarinic stimulation. Now, as we said, it's going to be vasodilate. Now, as we said, also, too much of everything can be bad, right? So, if you're vasodilating and if the person overdoses for some reason, there's going to be excessive vasodilation. It's going to cause low blood pressure. That's one adverse effect. And then there is it's causing bradycardia. It's causing sorry, decreased heart rate. Now, decreased heart rate could lead to bradycardia. Bradycardia is basically low heart rate. Okay, now, lower than usual, by the way, okay? And then it could cause nausea, vomiting, diarrhea. It could cause urination urgency a lot, okay? And it could also cause bronchospasm with increased bronchial secretions because there's going to be increased secretion. It could cause bronchospasm. So I hope all of that is clear. Now, coming on to the drugs, which is my favorite part. Okay, so coming on to botanicol and pilocarpine. Now, what you need to remember is these drugs, they have a certain action that is meant for a certain disease. And that's how we're going to remember them, okay? So we have botanicol. Now, these drugs are not hydrolyzed by acetylcholine esterase. That is why they have a longer duration of action from acetylcholine, okay? Now, botanicol, when do you use botanicol? Now, botanicol is used in patients that present with urinary retention, which is when they cannot urinate. And you remember all of these drugs that we were talking about in parasympathetic, they're going to help the patient urinate because you're relaxing, right? So you're going to use botanicol in these patients that present with urinary retention, so increase their bladder muscle tone so they can urinate. So that's botanicol, okay? Botanicol is for urinary retention. You give it to patients with urinary retention. Pilocarpine, on the other hand, what are the clinical uses of pilocarpine? Now, very important to also note is that pilocarpine can cross the blood-brain barrier, but pilocarpine in itself is used in glaucoma. Now, what's glaucoma? Okay, a glaucoma or glaucoma basically is it's a disease where you there's like high intraocular pressure and you want to lower this intraocular pressure. Now, how do you lower this intraocular pressure? You have to constrict your ciliary muscle. That's how you lower your intraocular pressure because it's going to increase the aqueous humor. Now, this is a bit complicated, but just remember that intraocular pressure, to lower it, you have to constrict your ciliary muscle. And your parasympathetic nervous system constricts your ciliary muscle because you want to focus, remember? So that is why it's gonna be used. Pilocarpine is gonna be used in patients with glaucoma, where where there's high intraocular pressure to lower it down. Okay, and it's also a drug of choice for emergency for reduction of intraocular pressure in general. Okay, so if there's high intraocular pressure, patients are given pilocarpine to decrease it down. Okay, now it's also given in xerostomia. Xerostomia is basically a condition where there's dry mouth. Again, we said in parasympathetic nervous system, the secretions are also going to increase. So if there is a dry mouth and you're giving a parasympathetic drug, this dry mouth is going to be counteracted and then your secretions are going to act again, right? So it's given in xerostomia, it's given in glaucoma, and also a drug of emergency to reduce intraocular pressure. So that's pilocarpine. Botanicol is given for urinary retention. So patients that present with urinary retention. Now, cevimeline, I hope I'm pronouncing that right, is again not hydrolyzed by acetylcholinesterase, and that's why they have like a longer duration of action. Now, clinical uses is it's used in Sjogren's syndrome. Now, Sjogren's syndrome is does have xerostomia, which is one of the it's one of the symptoms of the people that have Sjogren's syndrome. Now, you just said that your question could be, hey Rida, you just said that xerostomia should be treated with pilocarpine, but it says that cevimeline can also treat it. Yes, both drugs can treat it, but if there's a question and it has both the drugs, use cevimeline because it's more potent. Okay, so cevimeline is similar to pilocarpine and it's also used in xerostomia and dry eyes. Again, this is just based on secretions of parasympathetic. Now, methacholine is a drug that doesn't cause PBB, and the only reason that it was mentioned in your slide was for the metacholine challenge test to diagnose if there's a bronchial hypersensitivity or asthma for patients. Okay, because you can do that with bronchospasm and parasympathetic. So overall, what I want you to do is remember the parasympathetic functions and then correlate the drugs with it. And you're like, oh, we're going to give botanicol because it underfalls the parasympathetic class, right? And parasympathetic in itself is gonna, cause urination. And if patient is not able to urinate, you're going to give botanicol. If the patient has high intraocular pressure, you're going to give pilocarpine or sevimiline. Okay. If the patient, you want to diagnose asthma, you're going to give methacholine. Okay. Carbachol is not used clinically, but it was just there. So you just don't need to know it, but just know sevimiline, methacholine, botanicol, as well as your pilocarpine. These are the important drugs. Now, this is really important. So there's untreated eye. Now, if you treat your eye with pilocarpine or carbachol, right, it's gonna constrict the city muscle is gonna constrict. You're gonna focus. Why? Because pilocarpine is a muscarinic agonist. Atropine is the opposite. It's an antagonist, right? So if it's an antagonist, that means it's gonna dilate and it's not gonna focus anymore. So that's the dilatation of the pupil or dilation of the pupil. So that's mydriasis. If you want to constrict it, you're going to use the agonist straight up, which is going to be your pilocarpine or your carbachol. Now, inhibitors of acetylcholine esterase. Now, as we discussed, acetylcholine esterase is going to break down acetylcholine. What if we don't want to break down acetylcholine? We want to increase the availability of acetylcholine. So there's drugs that are reversible and irreversible. So reversible is, okay, it does go block acetylcholine esterase for a while. It's reversible, the mechanism of action, right? Irreversible is it cannot be reversed once it's blocked. All right, so we're gonna be doing the first drug, which is physostigmine. Physostigmine is a reversible acetylcholine esterase inhibitor. Now, if this is reversible, right, it's not letting acetylcholine break down anymore, right, because it's blocking acetylcholine esterase. So that means there's increased acetylcholine at synapses. Now, there's very two important uses of physostigmine. One of them is an antidote for atropine, and the other one is glaucoma. So an antidote for atropine, atropine is it's a muscarinic antagonist, okay? And what atropine does is it's gonna basically, because it's an antagonist, there's going to be more acetylcholine there eventually, anyways. When you administer a physostigmine, right, it's going to block the choline esterase. So your ideal question should be, if you're blocking the choline esterase, that means you're bringing in more acetylcholine. So isn't that going to make atropine worse? No, you're increasing the acetylcholine levels higher, higher, higher. And what happens is you increase it so high that it's going to reverse the effect of the atropine antagonist, and so the acetylcholine is going to be doing its function. It's going to go into the cells and whatnot it does, right? That's how you give it for an antidote for atropine. So physostigmine is given as an antidote for atropine overdose. Okay, so that's how that works. Side effects are going to be convulsions, bradycardia, also skeletal muscle paralysis, but that is going to be a higher dose, okay, because there's going to be acetylcholine accumulation. Now, neostigmine is very, very, very important especially for myasthenia gravis. I think it has been a question in every past, so it's a really important drug. Now, neostigmine in itself is going to improve muscle strength. Now, this is a very interesting way to remember it. Is in myasthenia gravis, your muscles get weak, and acetylcholine is basically going to go, give them activation or activate the muscles. So you don't want to break it down in the synaptic cleft because you need more of it, and that is why neostigmine is given for patients with myasthenia gravis. Okay. Now there's androphonium. Now androphonium is a short-acting one, and it's for diagnosis of myasthenia gravis. So if you want to diagnose the myasthenia gravis, it's going to be androphonium. Now, was this used for diagnosis? But the neostigmine is used for treatment Okay, well, androphonium has a short acting life. That is why it's used for diagnosis, right? And neostigmine has a long acting life, and that's why it's used for the medication or or the treatment of myasthenia gravis. So if you want to diagnose it, if the question says diagnosis of myasthenia gravis, you're going to do androphonium. If it says, like treating myasthenia gravis, then it's going to be neostigmine. Then you have donepezil, rivastigmine, and galantamine. What's important to know is donepezil, but just know these two as well. Now, they're just centrally acting acetylcholine esterase inhibitors, and they're used in Alzheimer's disease. Now, Alzheimer doesn't really have a cure of its own, but they can delay the progression of Alzheimer's disease by increasing acetylcholine in the synaptic cleft, which is going to go act on the central nervous system as well, not let the neurons die early. Okay, and then you have nerve gas and insecticides. Now, these two are irreversible, right? So, nerve gas is going to be irreversible inhibition of acetylcholine esterase. So, there's going to be excess acetylcholine accumulation. And that is why insecticides or nerve gases, there's going to be acetylcholine that's going to get accumulated in there, okay? So, it could cause severe respiratory depression and muscle paralysis. And that is when you're muscarinic antagonist, which you're going to see in the next lecture. For ecothiopate, right? It's an also long-acting irreversible, but it's topically sometimes used in glaucoma to reduce intraocular pressure. Okay, because it's a long acting one. So we discussed about three drugs for glaucoma, right? So I put them in a summary right here, just so you know. So you have pilocarpine that you give, right? And pilocarpine is a short acting one, so it's for acute angle closure. For neostigmine, it's also there, but it's a moderate duration and it's rarely used. If it's ever asked, usually about pilocarpine. Ectothiopate is long acting, but there's also risk of toxicity. So it's barely us. It's rarely used actually. Now, if you have to reactivate acetylcholine esterase, okay, you blocked it, but what if you have to reactivate it? You want acetylcholine to break down. You don't want it to be there in the synaptic cleft. Now, you remember how we said insecticides and everything is going to accumulate acetylcholine, okay? Well, it does elevate acetylcholine in the synaptic cleft, but we don't want it to be elevated. We want something to go reverse the entire thing. That's where PAM comes in, which is pralidoxamine. Pralidoxamine is used to reverse the acetylcholine esterase inhibitors to let acetylcholine esterase work to break down acetylcholine. And so, an insecticide or pesticide poisoning or insecticide poisoning, there's going to be more acetylcholine in the cleft, and you want to break it down, and that's why you use pyralidoxamine. And then you have like nicotine's action. Now, nicotine in itself is a drug that has both responses of parasympathetic and sympathetic. So it's not gonna the symptoms of nicotine are gonna be in both aspects, parasympathetic as well as sympathetic. So for let's say if it's cardiovascular, it's gonna raise the BP because it's gonna constrict your blood vessels, but it's gonna slow the heart rate down. So it's both, it goes both ways, right? Plus, at higher doses, nicotine can also have an antagonist activity. Okay, so that's that. And if you give nicotine for a prolonged period of time, it could result in depolarizing blockade of the ganglia. Now, nicotine in itself is just used to assist smoking cessation. So to you can cessation, so you can basically lead the people to quit. And it's usually used with varenicline. And it's also hydrolyzed by acetylcholinesterase. So this is just a table to summarize everything. These are all the direct muscarinic and nicotinic agonists, okay? And then you have the acetylcholine esterase inhibitors and all the related agents. So these are really important. They mention everything. So just go over them as a revision for the slides. So this is a checkpoint. I'm just going to drink water, and if you have not drank water, please drink it. And then we're going to continue. Okay, so question one. 23-year-old presents to the ER after accidentally overdosing on atropine. What is the mechanism of action of the medication that is to be used as an antidote? Okay. So the answer here is acetylcholine esterase inhibitor. If you want to be specific, it's neostigmine, okay? And we discuss why, because we're going to increase acetylcholine levels too high, so it could reversibly block it. Now, a girl diagnosed with myasthenia gravis, what drug would you administer? So she's diagnosed, okay? Okay, so this is neostigmine. Hold on, I said neostigmine here? No, it's it's pyrazostigmine. My bad, my bad. It's pyrazostigmine for the antidote for atropine. Neostigmine is for myasthenia gravis. Okay, that's it. Let's say, for example, the question was, so you're suspecting this patient to have myasthenia gravis. How are you going to confirm it? It's going to be androphonium, okay? Neostigmine is for the treatment of myasthenia gravis. Physostigmine is for antidote overdose, and we discussed why, because we're going to increase acetylcholine levels in the synaptic clefts, and that when it increases the levels, it's going to basically inactivate the atropine effects, which is the antagonist. So it's going to let acetylcholine break down, go in, etc. Okay, now coming on to the cholinergic antagonists. Okay, now cholinergic antagonists are basically these drugs are gonna block the action of acetylcholine. Okay, so we don't need acetylcholine anymore. Now, there's different types. There's anti-muscarinic, because we said there's muscarinic and then there's nicotinic receptors. So there's anti-muscarinic receptors or drugs, and then there's ganglionic blockers separate from neuromuscular blockers. Okay, because you remember how nicotinic receptors in itself had two different divisions for the ganglion and the neuromuscular junction. So that is why we have three different classes here. Okay. Now, for cholinergic antagonists, if you're um, inhibiting parasympathetic nervous system, you're activating sympathetic nervous system. So that's what it says here. Okay. So if you're inhibiting parasympathetic nervous system, you're basically activating sympathetic nervous system. Okay. Now, this was in your slides. It's a it's a really good diagram, right? We saw this earlier as well, but we're going to see where the site of all of these drug happens. So site of action of ganglionic blockers is going to be here. Oh, sorry, my bad. It's going to be here. Remember, this was NN, and this is NM, because this is neuromuscular junction, right? So this is going to be your site for NMJ blocker, if I'm right. Yes, NMJ blocker. And this is going to be your site for antimuscarinic right here. Okay, so parasympathetic. All of this is parasympathetic. But what's important to note is when you're talking about ganglionic blockers, remember that all three of these are going to get blocked. It's not just going to be parasympathetic, because sympathetic as well uses acetylcholine, and so does adrenal medulla, right? So it's gonna be, it's gonna all of these is gonna be blocked. So there's gonna be a mix of sympathetic and parasympathetic side effects. So let's start with atropine. And atropine is non-selective. So it's going to block all muscarinic receptors. To M1 to M5, it's going to block all of them. Okay. Now, it's a competitive inhibitor of acetylcholine at these sites. Now, we're going to discuss different side effects that it has and what it does, the mechanism of action. So in the eye, now parasympathetic was causing meiosis, which was the constriction of the pupil. Now, if you're blocking that, you're going to cause dilation. So that's going to be mydriasis, right? So in the eye, it's going to be mydriasis, which is pupil dilation. Okay, it's going to be the pupil dilation, and cycloplegia, which is inability to focus near. Okay, because we said that you don't want to focus anymore. Remember? Now, also, it's going to increase intraocular pressure. And as we mentioned, the atropine increases intraocular pressure, and this is really dangerous, and you have to avoid it in narrow angle glaucoma. Because remember, in glaucoma, you give a pilocarpine, which is going to decrease the intraocular pressure because it's already high. So atropine is going to increase it, and that's why you cannot give it in patients with glaucoma. Okay, for GI, GI is really important. It's going to decrease the GI motility. Again, we're talking about we're blocking the parasympathetic. So now it's going to block everything and it's going to put it into fight and flight mode, right? Because you're blocking the relaxing mode. So it's going to decrease GI motility. There's going to be antispasmodic action for the intestine. Now, the other thing is that it's very not effective on the gastric secretion, doesn't like affect the gastric secretion much, and that is why you give a selective drug for the gastric secretion, especially in peptic ulcers. Now, what is that drug? It's called pyrenzapine, and it's a M1 antagonist. M1, you remember, is for neural. It's also for GI, if I'm right. So M1 antagonist is pyrenzapine, which is used for peptic ulcer. Okay. And then dicycloverine is preferred for GI spasm relief. So remember, M1 was neural and it's also going to be GI. M2 is going to be the heart. M3 is going to be the glands as well as the smooth muscles. So if you want to relax, like prefer for GI spasm relief, so that's smooth muscles. That's why it's M3. But if you're talking about peptic ulcer, then that's GI in itself. So that's going to be M1 antagonist, which is going to be pyridine. Okay. So dicycloberine is for spasm. Now, and then you have urinary system. In urinary system, it's gonna just reduce the detrusor and constrict the internal sphincter. Now, we're blocking it out. You remember how we said botanical was used for people in urinary retention? Now, this is what you're doing here because you don't want anybody to urinate. That's the main outcome here is that you're blocking the parasympathetic out. So you're putting sympathetic in here. And if you're blocking parasympathetic, that means the urine output or there's going to be no urge to urinate anymore. Okay. And so that is why drugs like muscarinic antagonists like atropine is usually used in children, especially when they're bedwetting, when they're urinating a lot, because you don't want them to urinate. Okay, but it's supposed to be used in caution in elderly males due to BPH risk, because you don't know if they have benign prostate hyperplasia. Now, BPH is just when their prostate is it's constricted, and so they cannot pee already, and it's just gonna it's gonna add a negative effect to it, and it's going to be difficult for the patient. So you don't want to give it to patients that are old males, especially because they're at a high risk of BPH or they might even have BPH. Okay, so that's that for CVS. It's going to increase the heart rate because again we're going more towards the sympathetic side now, and it's also going to decrease secretions, and so that's why it's used pre-operatively to dry secretions, because you don't want secretions when you're doing surgery. So that's why you give atropine. Now, glands is also going to reduce salivation, everything secretion, everything's going to be decreased. For CNS, oh sorry, my bad. For CNS, there's going to be toxic doses, so there's going to be disorientation, delirium, hallucinations, and that's what we call atropine poisoning. So if a patient's presenting with disorientation, delirium, and hallucinations, then it's probably atropine poisoning. Now, there's therapeutic use. Now, why do you use atropine? If there's sinus bradycardia, because it's going to increase the heart rate. Remember, we're going towards the sympathetic side, so it's going to increase the heart rate. Also, as an antidote for insecticide poisoning. Remember, pyrzostigmine was used for an antidote for atropine, so that's why. And also for GI, urinary spasm, all of that, it's also used, but it's not specific, and that's why you use pyrazine for ulcers. For adverse effects, the patient is going to have dry mouth. Okay, it's like they can't pee, they can't sweat because there's going to be no secretions. They can't see because it's going to be dilated. They also can't sweat again because there's no secretions, right? And there's also going to be difficulty in peeing. Again, that's mostly because you're going towards the sympathetic side, and you're just basically gonna, the sphincter muscle is going to be constricted. So the caution, it should be used carefully with elderly and glaucoma patients and also BPH. Now, coming on to the classification of drugs, we have scopolamine and ipratropium. Scopolamine is very, very important because it's used as a motion sickness drug. Okay, so it's a muscarinic antagonist, and to just make it make sense, remember this. So you have parasympathetic, and that was increasing your GI motility, so that's going to lead you to more motion sickness, right? You want to not have GI motility at all. So that is why you're going to give antimuscarinic to decrease GI motility, and that's where scopolamine comes in. That's gonna, be used for motion sickness because it's gonna reduce your GI motility. Okay, and it's also gonna reduce salivation. So that's that. For adverse effects, there could be drowsiness and there could be blurred vision because scopolamine does cross the blood-brain barrier, and that's why it's going to cause drowsiness. Also dry mouth, again, because you're going more towards the sympathetic side, so now there's going to be less secretions, right? So that's that. And also confusion at high doses, again, because it crosses blood-brain barrier. Okay, now ipratropium is very important. Let me just write down that it crosses blood-brain barrier, so you guys remember. Okay, now ipratropium is used mostly for asthma and COPD patients. Now, the main thing that you need to keep in mind is when you're talking about parasympathetic, you're saying that there's bronchoconstriction. If you're going towards the sympathetic side, that's where there's bronchodilation. So that is why you give antimuscarinic, because you want to go from bronchoconstriction to bronchodilation, right? You want to inhibit parasympathetic because you want to bronchodilate. And that is why you give ipratropium. It's inhaled first off, and it's also going to block M3 in airways. So M3 is in the lungs, and it's just going to block it. And it's used for asthma and COPD. Again, there's going to be dry mouth, which are basically these common adverse effects of antimuscarinics in general, because they're going to decrease secretions, and also possible throat infection. And then we're going to talk about tropicamide and glycopyrronium. Tropicamide is a topical antimuscarinic, and it's basically given for ophthalmic exams, and it's usually also preferred over atropine. So atropine is also given, but it's preferred over atropine over for the ophthalmic examinations. Now, it's very important. I forgot to mention this, but atropine is used in ophthalmic examinations as well. Now, I don't know if you have glasses, but if you go for an eye checkup, there's always eye drops that they put in your eyes to dilate your eyes so they could examine it better. This is atropine or tropicamide. Okay, that's where these drugs are used for. But if there's a question and it has both options, tropicamide is much better because it has faster recovery than atropine. Okay, so atropine and tropicamide are both used for ophthalmic examinations. Adverse effects is going to be blurred vision. If you remember, when you do get an eye test and you come back, there's going to be like blurry vision, photophobia as well. You're going to be sensitive to like very bright lights and stuff. Okay, now glycopyrronium is just going to reduce saliva and bronchial secretions in palliative care. So again, we're going towards sympathetic, there's going to be less secretions. So glycopyrronium is used to decrease secretions. Tropicamide in itself is going to be used for ophthalmic examination. Ipratropium is for asthma COPD, and scopolamine is going to be for motion sickness. So these are your antimuscarinics. So atropine as well, it's really important. And we covered everything else too. Paranzapine and dicycloberine. Okay, then you're going to come to ganglionic blockers. Now we're talking about the ganglions, right? We said the ganglions are not only present in parasympathetic. Actually, even sympathetic preganglionic nerve fibers are going to work on acetylcholine. So there's going to be a total block. Yes, there's going to be a total block because every ganglion has acetylcholine in it. So when you're doing a ganglion block, you're blocking everything. Okay, so now the classic drugs under this are nicotine and varenicline. We kind of took nicotine and varenicline. Remember, we said nicotine in itself has both parasympathetic and sympathetic side effects. That is because it has ganglionic blocker abilities, and it blocks all the receptors or all the ganglions that could potentially go for sympathetic and parasympathetic. So that is why it has mix of adverse effects there. And it's just now because nicotine is usually now just used for, to suppress the craving in people that are trying to quit smoking, and so is varenicline. It's a partial agonist, but it's also used. Okay. Now the other drugs are hexamethonium and tubocuronine. Tubocuronine and hexamethonium are important. They're basically non-depolarizing blockers. So they're not used in clinical practice anymore, but all you need to know is that depolarizing blockers. Okay. Now effects of these is, remember, you're going more towards you're blocking ganglions, right? You're blocking parasympathetic and sympathetic both. So there's going to be inhibition of secretions, there's going to be GI paralysis, impaired bladder function, and also loss of cardiovascular reflexes, right? And hypotension. So all of these effects are going to be from these ganglionic blockers. So now they're not highly used in clinical practice because there's so many side effects, because it blocks sympathetic and parasympathetic, but it's good to know about them. So here it is. Nicotine is used for smoking, like for smokers that want to quit smoking. And hexamethylium, methonium, and tubicarine, all of these are not used anymore. They're experimental, or they were there as tubicarine was there as a muscle relaxant, because it blocked everything. So this was your FYI slide in the PowerPoint. What I noticed is there's mecamylamine here, and you just need to know that it's a treatment of moderate to severe hypertension, just so you have covered all the drugs in her lecture. Okay. For neuromuscular blocking drugs, right? You're blocking the neuromuscular junction now. Now, these neuromuscular junction drugs, there is going to be acetylcholine that acts there to open cation channels. Now you're going to just do a rapid depolarization, which is there's a rapid depolarization that's known as the end plate potential, right? But these drugs, they work by inhibiting this action of acetylcholine postsynaptically. Okay, so that's where this comes in and it blocks. So now there could be two types of neuromuscular blocking drugs. There could be depolarizing agonist or non-depolarizing antagonist. Now, depolarizing agonist is succinylcholine, which is succinylcholine. It's very important. Now, depolarizing agents, there we're going to get into this further, but non-depolarizing antagonists are going to be tubicarine and pancronium. Okay, now they're lower doses, they're going to competitively inhibit acetylcholine or block acetylcholine, and higher doses they're going to block the cation channel. Now, if you want a central muscle relaxant, it's going to be diazepam. If it's datroline acts on the muscle directly, but if it's central muscle relaxant, it's diazepam. Okay. Now, basically, when you're blocking your muscular junction, you are relaxing the muscle, you're paralyzing the muscle, right? And that is why these two are also important. They were briefly mentioned in your lecture, but just know if you want to relax the central muscle, you're using diazepam. If it's dentroline, then it acts directly on the muscle, okay? But depolarizing drugs such as succinylcholine, which is succinylcholine, it's gonna act on the it's going to act around the receptor, but what happens is it's going to first cause depolarization. So there's going to be twitching, and then it's going to get desensitized. Okay, so the first thing the patient's going to have is flaccid paralysis. There's going to be twitching because serotonin is initially destroyed esterase, right? But succinylcholine persists longer. And that is why there's going to be that flaccid paralysis that happens. Okay. So there's going to be depolarization first, and then it's going to just continue binding, and then there's going to be depolarization that further blocks impulses. And then that's when the resistance develops. Okay. So the phase one is going to be there's the initial discharge, there's going to be transient fasciculation, which is going to be flaccid paralysis because there is a depolarization that's happening in the channel, and then it's gonna just get desensitized to acetylcholine in general. Okay, so then that's when the paralysis is gonna take place, and it's just gonna be like muscle paralyzed. Okay. So first, flaccid paralysis, depolarizing, just remember the first thing that's going to happen is flaccid paralysis and then full paralysis, okay? For non-depolarizing, it's going to be the opposite. For non-depolarizing, it's straight going to go into paralysis, okay? So depolarizing blockers, the clinical actions, they usually use this for endotracheal intubation. They're also quick to produce muscle paralysis, and the respiratory muscles are also not affected. They're affected last. Okay. The adverse effects is going to be hyperthermia, which is going to be muscle rigidity, because of course it's all paralyzed, and especially with halothane. Halothane is just a type of anesthesia. So if you're giving halothane with your depolarizing blocker, it's going to cause hyperthermia. So you need to be careful. And then you have your non-depolarizing blockers, your tubicarine and pancronium. Now, these are not destroyed by choline esterase, and what you need to know is that they're not gonna cause flaccid paralysis at all. It's just gonna be diet paralysis. Okay. Now, tubicarine is largely replaced by pancronium, mostly because pancronium has less side effects. And we discussed that tubicarine is barely used in clinical practice anymore. Remember, we just discussed that in the ganglionic blockers as well. So less side effects, and that is why pancronium is used more than tubicarine. And so they're like competitive blockers, and that's why they don't let acetylcholine block, and they just lead it to, you know, um, muscle paralysis. Now, not all muscles are equally effective or affected. So the first muscles that are affected are face and the eye, and then the diaphragm is affected last. But the recovery, it happens from the diaphragm first. So the recovery is first diaphragm. Okay, and there's gonna be also some agents that may cause histamine release, which could lead to blood pressure drop and stuff. Okay, now non depolarizing blockers, how can you reverse them? Is you can use neostigmine. Remember, we said neostigmine can be used to reverse effects by increasing acetylcholine to compete at the receptor. As we said, it could be used for atropine antidote as well. Now, sugar mimidax can also be used, which it forms inactive complexes with drugs, and then it just reverses their effects. So the drugs are not going to be able to act. This was just in your slides. I added this here just so you can, orient yourself with how many drugs you have covered. We have covered almost everything in here. Now, this is just a table to summarize everything. These tables are very, short, and that's how I'd like to keep them, just so you know the clinical use mechanism of action and what the most common adverse effects are. And we're done with cholinergic. So this is question number 1. A young man had a car accident. Intubation was required. Which of the following helps in the procedure? Okay, so the answer here is succinylcholine. If you remember, it's a depolarizing blocker and it's used in endotracheal intubation. Okay. Now, a patient presents with excessive salivation, sweating, lacrimation, vomiting, diarrhea, and slow heart rate after ingesting wild mushrooms. Which one of the following is the first line treatment? So the answer here is atropine, because atropine is a muscarinic antagonist. Okay, and now we're going to start with adrenergic agonists. Now, to begin with adrenergic agonists, just remember that we're talking about the sympathetic nervous system now. We're done with the parasympathetic. Cholinergic was all of parasympathetic. Now we're going to talk about the sympathetic, which is adrenergic agonists. Okay. So in sympathetic, remember we said there's alpha and beta receptors. So alpha 1, beta, alpha 1, alpha 2, beta 1, beta 2. Now, how do these act? They're going to act by acting on norepinephrine, epinephrine, and also similar agonists. Now, they could be either direct acting, which is they're going to bind to the receptors and act, or they're going to be indirect acting where there's gonna they're going to bind to the receptor, they're going to act. Or indirect acting is when they're not going to let norepinephrine get reuptaked by your into your neuron again. And there could also be mixed acting. Okay, and that's it. We also have selective versus non-selective. Okay. Now there's catecholamines. Now catecholamines is norepinephrine, epinephrine, isoproterenol, dopamine, dobutamine, all of these. Okay. And non-catecholamines are all the other ones that are left. Now for the receptors, this is really important. So you have alpha 1, alpha 2, beta 1, beta 2. Beta 1, beta 2, they're going to work through GS. So that they're just going to stimulate the adenyl cyclase, which is going to increase cyclic AMP. That's what they do. Beta 1 is usually used in the heart, remember, and beta 2 is usually used in the lungs, okay? Now, alpha 1 and alpha 2. Alpha 1 causes vasoconstriction. So it's going to be GQ because it's going to cause vasoconstriction. So you want stimulation of the PLC, formation of IMP3, increase in calcium, all of that. So that's going to cause contraction, okay? For alpha 2, it is GI, which is inhibitory because it decreases in cyclic AMP. There's a decrease in cyclic AMP, okay? So these are all the adrenergic agonists. So you have alpha 1, there's going to cause vasoconstriction. It's sorry, my bad. 1 second. Okay, so yeah, so you have, oops, because you have vasoconstriction, contraction. In the vas deferens, there's going to be ejaculation, contraction, contraction, because everything is going to contract. Okay, alpha 2 is just going to decrease the transmitter release. For beta 1, as we said, it acts on the heart, as you can see, so it's going to increase the heart rate, force of contraction, all of that. It's going to also increase renin from the kidney. For beta 2, it's going to cause bronchodilation, so bronchial smooth muscle relaxation right here, because we said it's for the lungs. And it's also going to cause vasodilation. So alpha 1 causes vasoconstriction and this causes vasodilation. Remember that. Now, there's adrenergic agonists that could be selective and non-selective. Now, what does non-selective and selective mean? So we have 4 receptors. Now, non-selective means that these drugs can act on any of these receptors. Selective is, oh, they're selective for alpha 1 or they're selective for alpha 2. Starting off with epinephrine. So we have epinephrine, and epinephrine is the other name for adrenaline, right? And okay, I'm gonna use this one. Okay, now these activate alpha 1, alpha 2, beta 1, and beta 2 receptors. Okay, so it's non selective, and that is why it's gonna have a mix of symptoms. So there's gonna be vasoconstriction because it's alpha 1, there's gonna be increase in heart rate because there's beta 1, there's gonna be, also vasodilation skeletal muscle because it's beta 2. So all of this, okay? Now, pharmacokinetics is it's not effective orally. Why? Because again, we said it gets metabolized, remember, by monoamine oxidase and catechol transfers. So it cannot be effective orally. Indications is when there's a cardiac arrest, there's a cardiogenic shock, or even a cardiac stimulant. That's when you give them because it's going to increase the heart rate. Adverse effects is going to be angina, which is going to be severe chest pain, erythema, because again, you're increasing heart rate could lead to erythema, hypertension with the vasoconstriction, and also digitalis hyperthyroid patients. Okay, it also avoids and like finger to toe with local anesthesia. So this is what it does. There's going to be increased BP. Wait, hold on 1 second. Okay, it's going to be increased BP because vasoconstriction, mydriasis, retention of urine, tachycardia. So okay, then you have norepinephrine. Now, norepinephrine activates alpha 1, alpha 2, and beta 1 receptors. Alpha 1, again, is going to cause vasoconstriction. Beta 1 is going to increase the heart rate activity. It's going to be the same everywhere. If they're working on alpha 1, vasoconstriction. If they're working on beta 1, there's going to be heart rate. If they're working on beta 2, then there's going to be vasodilation in the skeletal muscle. There's also alpha 2, but alpha 2 is not as significant. Okay. For norepinephrine, it's going to treat shock because you need vascular resistance, you need high BP. So alpha 1 is going to increase the BP, okay? So norepinephrine is going to be helpful in treating shock. Then you have isoproterenol. Now, isoproterenol is also going to activate beta 1 and beta 2 receptors. So these are all non selective. You have epinephrine that is going to work on all four, alpha 1, alpha 2, beta 1, beta 2. You have norepinephrine that is going to work alpha 1, alpha 2, and beta 1. And then you have isoproterenol, which is going to work on beta 1 and beta 2. Now, beta 1 is going to increase the heart rate, contractility, cardiac output, as well as renin release, right? But beta 2 is going to cause vasodilation in skeletal muscle. As we said, it's also going to cause uterine and bronchial relaxation. Okay, so indications could be cardiac arrest, cardiogenic shock. Could also be used in asthma because it's going to cause bronchodilation. Okay, now adverse effects could be tachycardia again because you're going to increase the heart rate, so it might go up a lot. Now, this was just in your lecture. So this basically just shows that, how this is norepinephrine, this is epinephrine, and this is isoproterenol. So in norepinephrine, we know that it mainly activates alpha 1 and beta 1 receptors, right? And so it's going to increase the blood pressure a lot. And if when it increases the blood pressure a lot, it's going to reflex. So this is going to be alpha 1 and beta 1 blockers. Now it's going to increase the blood pressure a lot, right? And that's why there's going to be a reflex bradycardia because there's a lot of high blood pressure. And there's also going to be peripheral resistance that goes up, right? For epinephrine, it's going to stimulate both alpha 1, beta 1, and beta 2 receptors. Remember, it's going to like stimulate almost all of them, but the significant ones that we're going to talk about is going to be beta 1 and beta 2. So it also causes a modest increase in blood pressure, not as much as norepinephrine does. But because of that, it's going to increase the heart rate. Okay, and it also decreases peripheral resistance. So norepinephrine is the only one where there's going to be reflex bradycardia. Remember that. And isoproterenol just acts on beta receptors. So there is going to be peripheral resistance that drops a lot because it's acting on beta receptors, making the heart rate go up. So when this drops, the heart rate goes up. Okay, and when this goes up, the heart rate goes down. So opposite. Okay, then you have oxymetazoline. Now, oxymetazoline is also non-selective. It's going to be for alpha 1 and alpha 2 receptors. Okay, now it's usually used for topical nasal decongestant, but the adverse effect is there's going to be rebound congestion. So rebound congestion is you use it for 3 days. As soon as you stop using it, there's going to be a rebound congestion again because that's how these drugs work. Okay, so that's for oxymetazoline. And that's for it's for non-selective. So you had norepinephrine, epinephrine, isoproterenol, and you had your oxymetazoline. Okay. Now we're going to come into selective. Now for selective, you have salbutamol and terbutaline. Now, okay, salbutamol and terbutaline, they're beta 2 agonists. Okay, stop and think. What does beta do? We said lungs, right? It's going to be helpful in our lungs. So that's why salbutamol and terbutaline is going to cause bronchodilation because you're activating the beta 2 receptors. So it could be used in asthma patients, right? It could be used in COPD patients. It could also be used in premature uterine contraction because there's also vasodilation of vasodilation of the skeletal muscle. So premature uterine contraction, and inhaled is also preferred, and that's the mode of taking the medication. It's preferred inhalation for asthma patients. Adverse effects is going to be tachycardia, palpitations, hyperglycemia, and tremor. Tremor is the most common, so no tremor and tachycardia and palpitations. Okay. Then you have dubutamine. Dubutamine is going to activate beta 1 receptor. Now, beta 1 is for cardiac, right? So it's going to increase cardiac rate, cardiac output. Indication is going to be it's increasing cardiac output in congestive heart failure. So if there's congestive heart failure, you're going to give dubutamine because you want to increase the cardiac output, okay? And then the adverse effects is going to be tachycardia and erythema because, it might just increase it a lot. Oh, this is just a repeated slide. I just delete it. Okay. Right, there we go. So then you have dopamine. Now, dopamine in itself is just an endogenous catecholamine neurotransmitter. You know that it's a precursor for norepinephrine, epinephrine from MOL from first year, right? Now, dopamine has different doses, and at different doses can be different mechanism of actions. So if it's a low dose, it's going to cause renal vasodilation. Okay, so it's going to increase urine output. If it's moderate, it's going to increase cardiac output. So if low, it's renal output. Moderate is going to be cardiac output. High dose is going to cause vasoconstriction. Okay, it's going to cause vasoconstriction. That's going to increase the BP. Okay, so you have to be really mindful of what the dose for dopamine is. So low dose is going to be urine. A moderate is going to be a cardiac output, and the high is going to be vasoconstriction. Now, it's usually used in shock, acute heart failure, because of course, in acute heart failure, you're going to increase the cardiac output. And then low doses are sometimes used to prevent acute renal failure because you want to increase urine output. Okay, now dopamine acts on five main receptor subtypes. So there's D1, D2, D3, D4, D5. And D1 receptors like D1 and D5 receptors, their main effect is to stimulate adenyl cyclase. So they're gonna stimulate GS, increasing cyclic AMP. Okay, and so there's gonna be renal vasodilation, urine output, all of that. D2, D3, D4 are gonna inhibit their GI, so they're gonna decrease cyclic AMP. Okay, so basically D1 is going to cause vasodilation in renal vasculature. D2 or D1 like, which is D1 D5, is going to cause dilation in renal vasculature. D2 like, which is D2 D3 D4, is going to reduce prolactin secretion. Okay. If there's adverse effects of dopamine are going to be tachycardia, erythema, hypotension also because it depends on the dose, hypertension because if the dose is high, hypertension if the dose is low, right? Nausea, vomiting, also no CNS effect because it cannot cross the blood-brain barrier. Now, methyl dopa is essentially acting hypertensive, and it's an agonist and central alpha 2 receptors. Okay, so we talked about dopamine, and now we're saying methyl dopa is a selective agonist for alpha 2. Okay. Now, it's usually used as an antihypertensive, especially in pregnancy. It's really important. If there's a hypertensive pregnant woman and they're asking you what medication to give, it's methyl-dopa. Okay. Adverse effects is going to be it's going to cause depression. It might cause anemia, which is hemolytic anemia, hepatitis as well, which is the liver inflammation disease, and also it might cause sexual dysfunction, gynecomastia in men, and amenorrhea in women. Okay. Then you have phenylephrine. Phenylephrine is also selective for alpha 1. And if it's selective for alpha 1, that we know that means it's vasoconstriction, right? So it's going to raise the BP. Now, there's going to be contraction of the radial muscle in the eye because mydriasis. So dila- there's going to be dilation, yes. And then there's contraction of the bladder sphincter. Okay. Now, the clinical uses of phenylephrine is there's nasal decongestant, which is topical nasal spray. And the adverse effects is going to be hypertension, of course, because you're vasoconstricting. Also, it's also used as an eye drop for mydriasis. Now then you have ephedrine. Ephedrine is mixed. Okay, so we talked about selective and now we're talking about mixed, okay? So selective is all done. Now we're talking about mixed, which is ephedrine. It's a mixed adrenergic agonist. So it's originally it was from the ephedra plant, and the mechanism is to activate alpha and beta receptors directly, which releases norepinephrine. Now, clinical uses of ephedrine is nasal congestion, and because it's causes alpha 1 mediated vasoconstriction, so the nasal congestion, okay? Adverse effects is going to be high blood pressure, rapid irregular heartbeat, anxiety, insomnia, and also tremor and confusion and stuff. So that is the selective adrenergic agonists. They're all in this one table, just as an overview. And then there's non-selective adrenergic agonists, which are all in one table, just as an overview as well. And we're done with adrenergic agonists. It's really pretty easy, simple lecture. If you know what the receptors do, you can just, you just know what the drugs are going to do. Okay, so which of the following drugs is used as a nasal decongestant? So you talked about this is ephedrine, which was used as a nasal decongestant. Remember, because it's alpha 1, vasoconstriction, all of that. Okay. Now, a patient was given an overdose of a beta 2 agonist. What changes are you going to see? You're going to see hypotension because it vasodilates everything, remember? Okay. Question 3. What is the first line treatment of acute angle glaucoma? This question is from cholinergic. I added it here by mistake, but since we have covered it, we're gonna do it. The answer is pilocarpine. Okay, neostigmine is okay, so physostigmine was for antidote, atropine antidote. Neostigmine was for myasthenia gravis. Remember that. And now we're gonna be covering adrenergic antagonists. Okay, guys, so let's start with adrenergic antagonist, which is gonna be our last topic for the day. So, first off, we're going to start with adrenergic antagonists that are non-selective. For example, okay, to begin with, first, let's just overview what adrenergic antagonists are going to do. So they're basically just going to block adrenergic receptors, which is going to reduce the effects of norepinephrine and epinephrine, right? And they're also, again, adrenergic receptors are split into alpha and beta blockers. Now, getting into the non-selective blockers, we have phenoxybenzamine as well as phentolamine, right? Now, phenoxybenzamine is going to be, it's irreversible, but it also has a greater affinity for alpha 1 receptor, okay? And phentolamine in itself is like an equal blocker, so it blocks alpha 1 and alpha 2 both equally. Now, indications for phenoxybenzamine and phentolamine is going to be pheochromocytoma, which is just an adrenal gland tumor that's releasing a lot of catecholamines. So it's gonna cause like severe hypertension, peripheral vascular disease, and all of that. And that is when you give phenoxybenzamine and phentolamine, which is gonna block alpha 1 and alpha 2. If you're blocking alpha 1, you're basically causing hypotension, right? You're vasodilating, right? So that's gonna be so the adverse effects might be postural hypertension, which is gonna be like severe hypertension. When the patient gets up, they feel very dizzy because all the blood is pulling down. So that's postural hypertension. Tachycardia could be reflex tachycardia. There could be vertigo because of the vasodilation, sexual dysfunction as well. Okay, for phentolamine, it could be nasal decongestion, headache, vertigo and sexual decongestion. Nasal congestion and headache is also a part of because of the the vasodilation. So phenoxybenzamine and phentolamine are really really important for pheochromocytoma, and they're for alpha blockers. But phenoxybenzamine is alpha one. It loves alpha one more than alpha two, but phentolamine is equal for both of them. Then, coming on to the selective ones, so you have prazosin and tamsulosin. Now, prazosin is a selective alpha 1 blocker, and alpha 1 has alpha 1A, alpha 1B, alpha 1D. Now, indications of using prazosin is hypertension and benign prostatic hyperplasia. Now, hypertension makes sense because you're going to vasodilate. What's benign prostatic hyperplasia? This is just a picture. This is the prostate of a normal male. Now, a benign prostatic hyperplasia is when this prostate is hyperplaced. It's in hyperplasia. Now, hyperplasia is when it's enlarged, right? So because it's enlarged, it's gonna um it's gonna constrict the urethra, and now the urine is not gonna pass through, so there's gonna be difficult urinating. So that is why you give prazosin, which is selective alpha 1 blocker. So you're blocking vasoconstriction. So you're letting the patient have vasodilation, so it's gonna help them pee. Okay, that's what's the major effect for prazosin and PPH. Okay, and again, adverse effects could be postural hypertension, especially first dose syncope, which is as soon as you give the first dose, if the patient stands, they're gonna faint. So syncope is same thing. Okay. You also have tamsulosin. Now, tamsulosin is an alpha 1A blocker, which means it's uroselective, and so it acts mainly on the prostate and the urethra. Okay, so the best drug between prazosin and tamsulosin for benign prostatic hyperplasia is going to be tamsulosin because it's uroselective alpha 1A. Okay, because alpha 1A acts for the urethra and the prostate. Now, adverse effects is going to be dizziness, impaired ejaculation, because there's going to be vasodilation. So there's going to be impaired ejaculation. And it also does not cause postural hypertension or tachycardia. So it's good for the patient because it doesn't cause postural hypertension and tachycardia because it's only affecting the vessels around the prostate and the urethra. Okay. So we talked about alpha, now we're going to come to beta blockers. So beta blockers are selective and non-selective, okay? So mechanism, as we discussed, they're going to either have higher affinity for beta 1 or beta 2. And if they're beta 1 selective, we have examples of metoprolol, etinolol. If they're non-selective, it's going to be propanol and timolol, okay? So that's how you know um for the thing. Okay, one good thing is phenoxybenzoline and phentolamine are both non-selective, right? Prazosin and tamsulosin sin are selective but for alpha 1, okay? If it's sin, it's selective but for alpha 1. If it's all, then you're talking about beta blockers, okay? Good. Now, now, this is really important. So, right here, we said indications for beta blockers is remember what beta 1 and beta did too? So, beta 1 was for heart rate. Remember, we said it increases heart rate, it increased the contractility and everything. Beta 2 was for the lungs, and that's the functions for both the receptors. Now, for indications of when you're going to use beta blockers, is for example, hypertension, angina, myocardial infarction, cardiac arrhythmias, heart failure. All of this is where you're going to use your beta blockers. Also, glaucoma. Why glaucoma? Because you remember how we said that alpha and beta blockers, they're going to increase intraocular pressure, right? So if you're giving a beta blocker, it's going to decrease the intraocular pressure and it's going to be used for glaucoma, so you can treat it. Okay, so that's that. Um, Intrinsic somatomimetic activity is a really interesting concept. It is when there's some beta blockers that activate beta receptors while blocking them. So they're partial agonists and partial antagonists. So they're blocking it, but they're not blocking it completely. They're blocking it halfway. So like it's half agonist and half antagonist, if that makes sense. So this is really useful in patients. For example, let's say a patient comes to you and they have hypertension, but they're also bradycardic. Okay, a lot of times this happens. You cannot use a normal beta blocker because it's gonna decrease their heart rate even more. You want to treat the hypertension, but you can't decrease their heart rate even more. This is when you're gonna use penodolol or esomeprazole, which have an intrinsic sympathomimetic activity because they're partial agonists. So they're gonna treat the hypertension, but they're not gonna do anything to the bradycardia. Why? Because it's half activated and half unactivated. So they can't really decrease the heart rate to as an extent as a normal beta blocker, if that makes sense. So this is the clinical relevance. If a beta blocker with ISA is preferred if bradycardia is an issue in the patient, okay? That makes sense. This is just a diagram. You can see that it's going to be partially, it's going to be partially there. Then we come to azabutolol and pinodolol, which is exactly the ones we were talking about in ISA. We're just going to further talk about them. So, azabutolol is beta 1 selective with ISA, so hypertension and arrhythmias, because beta 1 was for heart rate, right? And it blocks beta 1 receptors in the heart, stimulates beta receptors weakly. Okay, so it's going to stimulate beta receptors, it's going to be weakly, and it's going to block the beta 1 receptors in the heart, so it's going to treat the arrhythmias and everything. Okay, so it's going to be less bradycardia and fatigue than non-ISA agents, okay? Now, penodolol is non-selective beta blocker, so it's not selective for anything. Acetylbutylol, it was selective for beta 1, okay? Indications is hypertension, especially in patients prone to bradycardia. So penodolol, if the person presents with hypertension and they're prone to bradycardia, you're going to give them penodolol, okay? It blocks both beta 1 and beta 2, but it's partial agonist effects, right? So it's going to reduce bradycardia. So adverse effects is going to be low risk for severe bradycardia. There's going to be a lot of risk for severe bradycardia. Also lipid disturbances, because other pure antagonists can cause lipid disturbances in patients. Okay. Then you have nebivolol and propanolol. Now, nebivolol is selective for beta 1 as well. So it's going to cause vasodilation. Now, it blocks beta 1, but it's going to stimulate nitric oxide to release. And when nitric oxide is released, it causes vasodilation. Okay. So nebivolol is vasodilation. Okay. Nebivolol is vasodilation. Now, adverse effects, it could, if you add it with other beta 1 blockers, it could have different benefits. It could not have benefits actually. Oh my God, sorry. It could not have benefits, but actually it's going to cause severe vasodilation. Now, for propanol, it's very important. Propanol is also non-selective beta blocker. The mechanism is it's going to block both beta 1 and beta 2 receptors. Okay. Propanol blocks both of them. And the indication is you're going to use it in patients with hypertension, angina, edemas, migraine, all of this. Adverse effects of propanol could be bradycardia because it's a full antagonist, right? Fatigue, vivid dreams, and CNS effects, right? Also bronchoconstriction because we said B2 is going to cause bronchodilation, but if you're antagonizing it, it's going to cause bronchoconstriction. Also worsened lipid profile. So worsened lipid profile is very important because there's going to be increased VLDL and decreased HDL. Okay, VLDL is bad, HDL is good. So HDL is decreased and VLDL is high. Okay, so that's very important to know. If a patient comes to you with worsened lipid profile and they're bradycardiac, they're having CNS effects, that means the patient has taken propanol. Okay. Okay. Now, beta blockers, of course there's going to be major therapeutic effects of them. So most of these effects are going to be on the cardiovascular system because we said beta blockers are mostly for the cardiovascular system, right? So it's going to decrease the heart contractility, heart rate, especially in patients that have like arrhythmias and stuff. It's really, really important. And they're also going to lower cardiac output and stuff, right? In vessels, when a beta 2 blockade does happen, it's going to oppose vasodilation, so it might raise the peripheral resistance. Okay, so it's like unopposed activity from alpha because alpha is going to vasoconstrict, so it's like unopposed. Okay, so that is why sometimes they give alpha 1 blocker as well. Now, beta 2 blockade in a bronchial smooth muscle may increase airway resistance, but that is why you avoid it in asthma patients because you don't want to give it into asthma patients, right? Because you don't want to bronchoconstrict their thing and cause airway resistance there. So that's that. And then you have chronic use, of course, as we said, it's going to increase VLDL and lower HDL cholesterol, but ISA ones don't do that. Beta blockers indication is going to be hypertension. You can lower BP because with the cardiac output, angina, myocardial infarction, arrhythmias, heart failure, all of this could be treated with beta blockers. Now, adverse effects is bradycardia, which is most common. And to treat this, you're going to use an ISA beta blocker if needed because it's a partial agonist. It's not going to decrease it as much. Bronchoconstriction, which is worse when it's with non-selective blockers. So because there's going to be opposing of alpha, so this is going to be worse if it's with non-selective. There's also cardiac arrhythmias. There's fatigue. Okay, and also you cannot just cut off beta blockers immediately. You have to taper it off to make sure there's no risks of arrhythmias or hypertension because it could come back, it could relapse. So it could also cause congestive heart failure, especially in susceptible patients. And then we have levetolol and carvedilol. Now, levetolol and carvedilol, levetolol is both alpha 1 and beta, but it's non-selective. And it's usually used in emergency cases to lower BP. That's what it's used for. And the major indication is just hypertensive. Like as soon as a hypertensive patient comes in, you could use levetolol as an IV to decrease the BP down. For carvedilol, it's non-selective beta blocker with also additionally alpha-1 blocking effect. So it's approved for hypertension as well as heart failure. So it's gonna basically, because it's non-selective beta blocker, it's gonna be more potent at beta than alpha-1 because it prefers beta, and it's gonna blunt catecholamine effects, which is useful for cardiac remodeling and heart failure. And then you have sympatholytic agents. So reserpine and guanidine. Now, sympatholytic agents, reserpine and guanidine, they're gonna basically they're just gonna remove catecholamines from the picture. So reserpine, it depletes catecholamines from the nerve endings by blocking the storage in the vesicles. Now, inhibiting alpha and beta receptor mediated events. Okay, so it's usually used for hypertension, but it's rarely used now because of the side effects. And the side effects are like insomnia, sedation, depression, all of this. Because catecholamines are not, they all regulate different types and different sorts of things. Then you have clonidine, which is going to block calcium dependent release of catecholamines. So it's also blocking release of catecholamines. So it depletes catecholamines over the long term. It could cause hypotension and bradycardia. And it was used for hypertension, but it's no longer used. Okay, so it could cause hypertension and bradycardia. So this is just a table to summarize everything again. It's really important to know the clinical uses and the adverse effects, and we're going to be good to go. This is for the non-selective, and that's it. So we have a final set of questions. Which of the following is the pharmacological treatment of pheochromocytoma? It's phenoxybenzamine that is used, and phentolamine as well. But phenoxybenzamine is the preferred one. Okay. The patient presented with BPH and got treated. Which receptor is targeted by the drug? It's really important. We said it's a specific receptor in the urethra and the prostate. So answer here is C, which is alpha 1A, because it's a specific receptor for the urethra and the prostate. Now, which one of the following drugs is contraindicated in asthmatic patients? Okay, so the answer here is propranolol. Why is it propranolol? Because propranolol is both, it's non-selective for beta blockers, right? And it's gonna be contraindicated in asthmatic patients because beta 2 is for the lungs, remember? And to logically think about it, sympathetic nervous system causes bronchodilation. Because if you're blocking that, it's going to cause bronchoconstriction. So it's going to be contradicted in asthmatic patients because you don't want to bronchoconstrict their trachea again because they're already having difficulty breathing. So that's why it's contradicted. And that's it. Thank you guys so much for making it this far. Please remember the QR code for feedback. And I hope this session was useful to you. And inshallah, your PhD exam is going to be great. Take rest, stay hydrated, and inshallah, you guys are going to ace it. If you have any questions, please feel free to reach out to my number and ask me the questions anytime. And I hope you have a great exam. Thank you guys for watching this lecture.